So, what are some of the things that you would want to be thinking about when you're examining someone and then you think that you want to go forward with syntonic phototherapy? So, the first thing is what happens when you do a history? What are the symptoms that the patient has? And whether it's syntonic phototherapy or just generally, we have all our patients fill out some type of questionnaire. In this case, this is a 25 questionnaire. This is very much like the what was called the COVD, I guess now would be the OVDRA questionnaire. And patients can rate each one of these, whether it's something that never happens, sometimes happens, always happens. Usually we have them rated between a scale of 0 and 5. And then when you add up the number of points that they have, if it's over a certain number of points, usually the early 20s, then you know that there may very well be a visual issue that needs attention. The other thing is, it's a very useful questionnaire to give at the beginning and then to give later after treatment, because sometimes patients don't always notice how much things have changed. And if you have them fill it out again without seeing what they did the first time, they're often amazed at how different it can be. So in syntonic phototherapy, we talk about the autonomic imbalance, and there's a couple of things that we look at that really show us that. One is called the alpha omega pupil. What happens is, if I shine a light in your eye and your pupil constricts, it should stay constricted for some period of time. In the literature, they don't always agree on exactly how long, but we say at least 10 seconds. If someone has what we call our alpha omega pupil, it's the inability to sustain that constriction under the light. And so you get a very fast dilation. In general, they feel the faster the dilation, the smaller the field. And the poor constriction in general can be a sign of visual fatigue. But most of the time, when you shine a bright light at the eye, the pupil will constrict. But what happens when they have the alpha omega pupil, it almost immediately redilates. It does not stay constricted. We also see a lot of oculomotor imbalance, primarily because the visual field is constricted from a performance standpoint. It's not a disease field, but it is overall constricted. And so when it's overall constricted, you can get very poor pursuits and saccades, and you'll also notice more head movement versus eye movement, because it's a little bit like looking through two towel tubes in front of your eyes or a pair of binoculars in front of your eyes. And you can see everything clearly, but you can't see a lot all at once. Now, John Pulaski, who unfortunately passed away last year, was someone who was very big in syntonic phototherapy in the College of Syntonic Optometry, and he did a tremendous amount of work looking at pupil responses and the alpha omega pupil, and he came up with a few things. One, what are some of the testing standards? So we want to look at how quick pupil releases. Can we look at the amplitude of release with certain pupilometers? You can do that. What's the reaction after the initial release? Does it just get larger and stay there, or do you get these fluctuations almost like a hippus? And what kind of change in response do you get with repeated stimulation? Obviously, even in the normal pupil, you will get some because it's already been stimulated if you don't wait long enough for it to recover. But it can be different when you see the alpha omega pupil. And are there any sensory reactions like tearing or pain? And then he devised this scale, which said, okay, what's the normal pupil release time? Now he says 7 seconds. That is a little faster than you'll often read in the literature, but we generally hold the light for 10 seconds. but you want it to stay constricted almost the entire time you have the light on their eye. And you may see a little bit of fluctuation or maybe a trace change to the amplitude, but it's a normal pupil. And then you can see he scaled it from 1 to 4 for the alpha omega pupil. And obviously the release time gets less and less or I should say really more and more, because the release time becomes less than a second versus 7 seconds. And the fluctuations he found are more moderate in the beginning, but then mild later, if it, which is interesting, because you would think that you would see more fluctuation, but it goes back to dilation so quickly you don't see as much fluctuation. And then the amplitude change can be quite large. Also, you sometimes will find that there's reduced color discrimination on the Ishihara plates. It's not necessarily a color deficiency, but we do find when fields are constricted, you sometimes lose your figure ground perception. And so you don't see it because you're not making that distinction between, let's say, the number and the background. The biggest thing we look at is functional visual field. Now, these are visual fields that are reduced, but in the absence of an organic cause. So we get what we know is a constricted field. It doesn't look like any of the fields you've probably learned in terms of eye disease. It's overall constricted usually, and it is often very, very small, and I'll show you that. But you get this functional visual field change. And we call it functional because it's in the absence of organic means. So, for example, this is pretty much a normal field in the sense that the black line would represent a white target. And then we also do color. And green tends to be the smallest, then red, then blue. And besides the white line that would be when they notice or when you hold a white target there and they see it, just before that, we also measure the motion field, which means that as I bring a target in from non-seeing to seeing, I want them to tell me when they notice it, when it's moving. Usually right after that, if I stop moving it, they'll also notice it. But sometimes there's a bit of a gap. So the motion field is a little larger. And then when they can see it without it moving is a little bit smaller. And then we test the green field first, just so that it doesn't really interfere with the fields that should be larger. And then we test the red field and then the blue field. So again, motion is the extreme periphery where we're going to get it, but we'll know a target is there, but we don't recognize its shape or its form or its contour. And then when you then see the white target, there's usually a small circle. And when you see it, it means you can then recognize a contour of an object, and you retain that perception when the target isn't moving. That's called the form field. So you start off with the motion field, then often very close to that is the form field. Sometimes there's a little bit larger gap. And then we do the colors. And we test the green and red and blue because we want to go from the smallest field to the largest field, primarily because you don't want to be interfering one versus the other can be a little confusing to the patient. And what we don't want to see is what we call interlacing or overlapping, and I'll show you pictures of that. And then we also try to plot the blind spot. And one of the things that you will find is often that blind spot is enlarged. They used to say because maybe there was some optic nerve swelling, but generally now with OCT, we see that that may not be the case. And so there's a new theory where they say it's an anomalous projection. So here's one where the visual form field is less than 5 degrees in all meridians, and we do see fields like that. You'll see some pictures coming up. And then this one is more full in terms of the form, but the colors are more constricted. So while the colors should be a little smaller than the white, they are a bit smaller here than they should be, even though they would generally be inside the white. And where you see those X's around the edge, that's the motion portion. And then you can see where they mapped the blind spot. If you have toxicity or you have brain injury, one of the things that you'll frequently notice is either inferiorly or superiorly, you get this kind of dip in the field. And it's pretty profound. I've seen it many times, and it's kind of a hallmark to some extent of someone who's generally, for me, it's someone who's had a brain injury. When you look at the blind spot, you can see on the top left that it's fairly normal. Now, it's a little smaller than the circle that's already on the field, but it's within that normal range. And then on the top right, you can see it's a little bit larger than the average field. On the bottom left, it's even larger. And on the bottom right, you can see that it maps quite irregularly. And that's the kind of thing that you see when you can plot the blind spot. Remember that that blind spot is out at about 15 degrees. If you have an overall field that's smaller than that, you're not going to be able to plot the blind spot. So what is light action on the visual system? Why is light so important? What's the pathway? What's the effect on the autonomic nervous system? And what's the frequency of light, the different frequencies that we use, and how they affect the visual system? So basically, there are non-visual photoreceptors of the deep brain, and they're in the pineal gland, and we know they're in the retina. And I'll show you some pictures of this. It'll be much easier in a moment. And the light reaches what's called the suprachiasmatic nucleus of the hypothalamus and ultimately ends up at the pituitary gland, where we get cortisol or stress hormone. So the retina and light hitting the retina influences the suprachiasmatic nucleus, and from pituitary it ends up hitting the pineal gland, and the pineal gland is where melatonin production starts. And while this is not a lecture about that, it's really important that we get suppression of melatonin in the morning so that we're awake and stay awake, and that we provide our bodies with the right opportunity in the evening so that melatonin is produced and we can sleep appropriately. And that's a whole other lecture in and of itself, but something to think about. So here's a picture, and basically you have light coming into the eye, and you can have it stimulated by darkness, or you can have it inhibited by light in terms of the melatonin production. But the light coming into the eyes goes through what's called the retinohypothalamic tract to the hypothalamus, or the suprachiasmatic nucleus of the hypothalamus. It travels down to the superior cervical ganglion, back up to pineal gland, and ultimately to having the melatonin production. It does say at the bottom here the structure of melatonin, but that was actually another picture that was just below this, and I wanted you to see this blown up enough to see it, and the structure of melatonin is not so important to the discussion here. This is just another short way of showing it. So light coming into the eyes through the optic nerve to the suprachiasmatic nucleus of hypothalamus, through what's called the paraventricular nucleus, through the spinal cord to the superior sympathetic ganglion, the pineal gland, and you have then a loop also to pituitary. And again, one more picture, just blowing it up a little bit so you can see it a little bit more. And some explanation of it, but I've already gone through that. So again, the effect on the autonomic nervous system is that we'll get this alpha omega pupil. You can't sustain constriction under direct light, so it means there's a lot more sympathetic activation than there should be. The poorly controlled pursuits and saccades, and often reduced color discrimination. So when we think about syntonic phototherapy, we often name the colors using Greek letters. But basically, we look at it as this kind of balance board. And what happens at the balance board is, if you're near the middle, if you're near where it says the word syntony, which means balance, the colors that are near that center are less strong. The colors that are at the very ends, farthest from that center, farthest from the word syntony or that triangle that's underneath, those are the stronger colors. So when we're treating someone, we will always use stronger colors first and less strong colors second, because we want to leave someone very close to the normal state of balance that you would want them to have. And the red end of the spectrum tends to provide more sympathetic stimulation, where the blue end of the spectrum tends to provide more parasympathetic stimulation, again, when there's an imbalance. And so what happens is, like I said, the center is more gentle, and at the center, we have a combination of two colors called mu upsilon, which is a blue end color, and we have on the red side what's called mu delta. At the ends where it's more stimulating, the blue side has something we call upsilon omega, or the two colors are upsilon and omega. And on the red side, you have alpha delta. There also is a combination called upsilon omega D, and that adds a little bit more blue and is much stronger and is used a certain amount of the time, especially in brain injury patients, but we often can't use it right at the beginning because it's too stimulating, and even though it should be calming, it's stimulating their system in a way that they can't really handle it, and will often have to wait a little bit to bring it in. So again, the red end is more sympathetic stimulation, tends to stimulate more of an exo response, generally thought of for more chronic conditions, whereas the blue end is stimulating the parasympathetic side, stimulates more of an ESO response, so you would be using it more with someone who is exophoric or exotropic, and it's considered useful for more acute conditions. I've used it even to treat like a corneal abrasion, and headaches, it'll bring some of that pain down right away. And so think of it as that sort of calming color. In the middle, we have what we call alpha omega. So it's a little bit of red and a little bit of blue. And we find that's more of an emotional stabilizer because it can balance sympathetic and parasympathetic. Now, why do we want to use red? Again, sympathetic activation stimulates the exo response. We think of it more for amblyopia and esotropia and any condition that's more chronic. And here are some of the colors. Because in optometry, we've gone a lot to various syndromes or grouping of symptoms and give them a name, We have, through the College of Syntonic Optometry, come up with various syndromes that fit the kinds of colors that we use. So this syndrome is called mu delta. It's what we call the chronic syndrome. And we're looking to have it be a physiologic stabilizer. You're generally going to see that the need for that in a patient who has convergence excess, esophoria, or esotropia. You also will see an alpha omega pupil, and they may have poor oculomotor control, but both of those things tend to go along with any of the aspects of the system being out of balance, so they aren't as easy to use in terms of what color are you going to choose for the patient. You may see a constricted field for form or color, and you'll often see a low recovery on ductions, especially base in. And along with esophoria or esotropia or a convergence excess, there may be more of a neuroendocrine imbalance in some of these patients, and they may have some chronic health problem. Also, some of them will tell you that there has been past trauma. And you want to stimulate the sympathetic and create more of an exo response. So what we tend to do is, rather than using just this color alone that's near the center of the balance board, we also often use a stronger color first. But one of the things that we found is that if someone's visual field is very constricted within 10 or 15 degrees, so inside the blind spot, you may want to use the color that's closest to the middle first, and then you want to add the stronger color. Because if you move too quickly, then the patient may not be able to tolerate it, or you may not be getting the response that you would like to be getting. And we'll show you more of that. So generally, the treatment protocol that we use is this. You're putting a certain frequency of light into the eyes. The session runs around 20 minutes. Because we generally do, if we're doing 2 sets of colors, we'll do 10 minutes of one and 10 minutes of the other. We generally say that it needs to be done 3 to 4 times per week, and we do a progress evaluation about every 8 sessions, where we're going to repeat their history, we're going to redo the visual field to make sure that things are changing in the right way. And we usually find that we need to do a minimum of 20 sessions. Some patients will need more, especially those that have had some significant accident, injury, trauma. But overall, it has very low risk and very few side effects. So I'm going to show you a few cases. I'm not going to take the time to give you the whole history. We don't have time for that. But just to give you an idea of the kinds of things we see. Now, the fields I'm going to show you were done a long time ago. They were done when we did them only by hand. Now they have some software where the field can be done in an automated fashion, and it comes out looking a lot sharper and cleaner. I think there are reasons to think about doing both. For research purposes, and I'm involved with some of that, we're using the automated field because we can control then what each person is getting when we're talking about a research project. From an everyday standpoint, sometimes it's nice to do it more manually and see the response. But again, if you're doing it manually, there's no guarantee that I'm moving the target exactly the same speed all the time or holding it exactly the same way. So if you can do it on the automated basis, then you know that it's showing the patient the same thing every time. So in this case, this is someone where we started with mu delta. And you can see here that this field is very constricted. That's one eye, and then here's the other eye. And then what I did to show you how it expands, I just picked one eye to follow because otherwise it was too many graphs here. But you can see that it's starting already within a short period of time to expand, and then it gets even larger, and now it's quite large. Now, the second syndrome we talk about is what we call the lazy eye syndrome. I don't love the term lazy eye, but people use it. And it's because we're looking at filters that tend to be both sensory stimulating and motor stimulating. And in this case, what comes out as a red-orange color is using alpha and delta together. This is generally for amblyopia, some for esotropia, with poor accommodation, when the fields are quite constricted, and you'll often see reduced divergence ranges. So the symptoms are obviously reduced acuity in one eye if they have amblyopia. You may see a head tilt or turn. Their stereopsis is often low. They may complain of double vision, and very often their reading speed is slow and their handwriting is not the best. And what you want to do is stimulate the sympathetic, especially if it's a long-standing strabismus. And alpha delta is the strongest stimulant. We find in very young children we need to be a little bit more careful in how we use it. But also, any patient with esotropia or esophoria may be sensitive generally, and it's a pretty strong stimulant. So if I can't use it for a full 10 minutes in the beginning, because then I'm going to go to something like mu delta, which is less strong, I will do it for a minute or two. If they can handle more than that, maybe 5 minutes. And I make up the difference to the 20 minutes with the other color. So here's someone where we looked at alpha delta because look at how small that initial field is. And there's the other eye. And as you can see, it doesn't take very long to get that field to begin to expand. Now, just as kind of a recap here, on the red side, we may want to use mu delta alone until you get about a 15-degree field. Then you would use alpha delta with mu delta, primarily for amblyopia and esotropia. But we can also use alpha omega, which is that emotional stabilizer, with mu delta. So it would be alpha omega with mu delta. And no matter what combinations you're using, whatever is closest to that middle section is what you want to end with when you end a session. Now, alpha omega, we talked about it being for emotional fatigue. You will see pupil changes. There can be adrenal fatigue. There maybe have been emotional trauma. Maybe there's just overall exhaustion and the visual system is just playing from that. Or you can also find the person goes through a lot of mood swings. And so alpha omega becomes the emotional fatigue syndrome, and you will see an alpha omega pupil. Sometimes you'll see a fatigue exo, and so you have to think about that because are you going to use red or are you going to use the blue end if you see someone who's demonstrating even an intermittent exotropia? You may want to know how long has it been there and when and how and where was it noticed so that you can make a determination of where it's sort of coming from. And then when we see patients like this, they will have low breaks and recoveries on vergences, especially for base out, and often they demonstrate adrenal fatigue. They have photophobia, transient blurred vision, again, overall fatigue, but related to the visual piece, and headache. And we're looking to balance the parasympathetic and the sympathetic. So again, we can use alpha omega with mu delta because you want to always end near the center. Even though alpha omega is kind of at the center because it's a combination of red and blue, it's considered strong enough that you want to end with something else that's very close to the middle. Here's another patient. Again, small field, a little bigger on the side. But look how much it changes. Now, what you see back here, this little dip, can be because of the history. We said we'd see it more with brain injury and certain kinds of trauma. But sometimes you just get these funky changes in between. And if you keep doing the therapy, they will kind of work themselves out. So again, just repeating it because I have to tell you, when I took the what's called the 101 course that the College of Syntonic Optometry gives, I took it probably 3 times over a series of maybe 3 or 4 years because you go back, you do the work, you have more questions, you take it again, you get more information, or you hear it differently. So don't think you're going to learn this from doing this. I'm hoping to offer a College of Syntonic Optometry 101 course, maybe in a few months. I was supposed to do it in March in India, but because of the situation in the Middle East, I wasn't able to travel. So I'm working on trying to reschedule that at a time that maybe many of you could join us. But again, mu delta alone, alpha delta and mu delta, and then alpha omega and mu delta. And I'll tell you, in the beginning, the hardest thing was for me to learn all the Greek names and keep them straight in my mind. So let's go to the blue end. Why the blue colors? Well, parasympathetic activation, stimulating more of an ESO response. It's very good for pain or spasm and more acute conditions. The mu upsilon or acute syndrome is often for recent head trauma, maybe a history of anoxia or stroke. The diagnosis is that you see that the patient has exophoria or exotropia, maybe convergence insufficiency, and the hallmark of what's been called post-trauma vision syndrome. They will often show an alpha omega pupil, an enlarged blind spot, poor oculomotor control, and accommodative control. The symptoms can be headache, motion sickness, vertigo, transient blurred vision, or double vision. And the double vision is often monocular diplopia, which is less seen than we normally would see some level of double vision in someone who's having difficulty fusing, but it is certainly seen in these patients more. And you're looking to stimulate the parasympathetic. And here's a patient where, again, the field was very small. They had a history of head injury. And it didn't take, in this patient, very long for us to be able to expand the field. At the blue end, mu upsilon is closest to the center. You may need to do that alone until the field enlarges. Then you would use upsilon omega and mu upsilon because you always want to end with a color that's at the middle. Now, just below or above, however you want to look at it, but next to the, let me just go back for a second. So you have mu upsilon that's very close to the center of that balance board. It's really the last blue color toward the center. Omega is kind of next to that. And we find that we can sometimes use that alone with children, sometimes before the patient can tolerate upsilon omega, which is the deeper blue. We may be able to give them some omega. And sometimes because we want to go slowly because we're not sure if the patient can tolerate more, then we might think about this, especially because today Where you are, you may see patients almost every day or 3 to 4 times a week. You can do all the therapy in office. But here we tend to see patients weekly, and we need them to be doing this therapy 3 or 4 times a week. We used to ask them to come to the office that often, but it became harder and harder for that to happen. So we generally have some home instruments that we send, and we are then not in a position to be monitoring the patient quite as closely. So sometimes we'll go a little bit more carefully or a little more slowly just to be sure that they don't have some adverse reaction when they're home. Now, this isn't a syndrome, but upsilon omega, which is the deep blue, is considered a pain reliever. It's very good for headaches, for general asthenopia, typically used with trauma, although again, a lot of trauma patients or brain injury patients, stroke patients, they can't tolerate it in the beginning, so we sometimes have to stay more toward the center and gradually bring in the deeper blue. If we're doing it together, we can use upsilon omega first and then mu upsilon. We find that we use this combination frequently with brain injured patients. But again, we may be doing 15 or 16 or 18 minutes of the mu upsilon and the upsilon omega we'll do first, but we might only be doing that for a few minutes until they can tolerate it more, or until we certainly see the field to be at least 15 degrees. Again, same thing we mentioned earlier, the frequency of light into the eyes, 20 minutes per session, a minimum of 4 times a week. Generally, we do a progress evaluation about every 8 sessions, where we'll repeat the history, the visual field. I'll likely do some of the near point tests that I've done to look at how their eyes are balancing. Are they now having a better range, both in terms of base in and base out? Are things more even than they were, so that one side isn't very good and the other side is very poor? And again, it has low risk and few side effects. Here's a patient who had an injury. And there's a couple of weird lines there because in the middle, they weren't really sure of their response. And overall, it's quite constricted. And they mentioned when we did the left eye that it wasn't as clear to see the target as the right eye. And then over time, you see the blind spot's still a bit enlarged, but the overall field is improving. And here it's much, much better. And here you get that little dip at the top there, which again, may be because it can't get better than that, but it may also just be that their system is needing time to come to a better balance. And often you will see that dip sort of even out over time. But again, we do see some of that constriction, either superiorly or inferiorly, with brain injury. And so sometimes it doesn't go away completely. Now, there is one other combination. There is a filter called D. And when you take upsilon omega and you combine it with D, it's the strongest blue color that you can use. When someone has significant pain or trauma, we use it. Like I said, I've treated, for example, corneal abrasions, and that's what I use. If patients have a history of loss of consciousness, though, we find that they don't do very well with it, or it's kind of disruptive, so we tend to stay away from it in patients that have that history. But if I'm going to do it, I'll do upsilon omega D and then the mu upsilon, because I'm treating it similarly to upsilon omega without the D. So again, you're going to think about mu upsilon alone. You may do omega alone, and then you can do upsilon omega with mu upsilon, or upsilon omega D and mu upsilon. And you always want to end at the middle of that balance board. Let's just quickly go through a case. So you've done a case history with someone, you get the quality of life questionnaire. I'm not going to say how many points they have. I just want you to know that when you're doing a case, that's something you want to do. In this case, it's someone who's had a brain injury. Their symptoms are blurred vision. You're certainly finding an enlarged blind spot. There is some visual acuity loss. They appear to have exotropia. They're complaining of double vision, loss of depth perception. Sometimes there's kind of a hyperarousal of sympathetic, so that you'll see that they're not sleeping well. They're always kind of moving around. There are other things that you can look at and even look to help them. But from your standpoint, you want to know, how does syntonic phototherapy begin to help them? And so they'll show an oculomotor dysfunction. They may skip or reread lines of print. Again, poorly controlled pursuits and saccades. If there's convergence insufficiency, they'll generally say reading is hard, or they get very tired. Some people even get dizzy or nauseous. And sometimes when you're coming at them to do a near point of convergence, they're moving as much as you're moving toward them, they're moving away from you. So I always say it's good that I have like a headrest on my chair, because there's a wall behind my chair, and if it wasn't there, their head would probably go through the wall. They'll often show an accommodative deficit with reduced amplitude and flexibility. That's something too that I've had to caution some other people who think doing near point of convergence activities like pencil push-ups can be useful, because if you have someone who's probably older than 35 and they're already a bit pre-presbyopic, often if they have an accident or injury, all of a sudden what they need is plus for near. And when they don't have it and someone is pushing them to do some type of convergence activity, it's very hard for them. And in some cases, they can even become myopic. So I have to say to them, look, I'm not happy you're doing vision therapy at all, but if you're going to do some aspects of it, at least know that if they're over 35, you shouldn't be doing all this near work. Often you'll also see decreased blink rate with dry eye, with photophobia. You'll see a reduced tear breakup time, and sometimes filamentary keratitis. The visual field constriction, they're going to bump into things. Maybe they have more difficulty at night. They get a little bit more disoriented spatially, often have an attention deficit, or they're always in motion trying to get information in. You'll see the alpha omega pupil. You'll see oculomotor dysfunction. Maybe what's been termed a midline shift, although it's probably better called that what's affected is egocentric localization. So you call it an abnormal egocentric localization. The reason I say that is because in medicine, they use the term midline shift when someone has a brain bleed and the blood fills so much of the brain's cavity that the actual brain gets pushed over to one side. They call that a midline shift. And so I think we need to change our language, besides the fact that it's not describing it quite as well as saying they have an abnormal egocentric localization. And they may have difficulty processing information. The treatment protocol is the same as we've talked, but most often you are looking at upsilon omega, mu upsilon, and you want to bring them back every 8 sessions, repeat the history, whatever parts of the vision analysis you want to do, and the visual field. And so just to kind of review, why are we doing red, orange, or lemon? Well, sympathetic activation, sensory and motor stimulant, primarily for amblyopia and esotropia, and it's stimulating an exo response. And here's one of the treatment protocols, the alpha delta and mu delta, generally 10 minutes each, or the alpha omega mu delta, also for 10 minutes each. Why the indigo or the turquoise or the blue end? parasympathetic activation, sensory and motor depressant for pain and spasm. That stimulates the ESO response. So the omega can be used in children. It's a weaker blue, but if you're trying to go a little stronger than mu epsilon, you can use omega by itself. Generally, we think about epsilon omega or even the epsilon omega D with mu epsilon. And the deeper blue, it says here, is generally used for 5 minutes unless pain or headache is severe. I sometimes will do it the full 15 minutes, but frequently it is too much for many patients, and so we do it for 5, maybe up to 10 minutes, and then 10 minutes of the other color. So because we can't always get to the 10 minutes for that one color, we may do 5 minutes and then 15 of the mu epsilon. Again, just reminding you of the treatment protocol again, about 20 minutes per session, 4 times a week. And after treatment, there should be more of a restoration of visual field, like those visual field constrictions you were seeing. You get improved oculomotor and especially binocular status. The headaches will decrease, the asthenopia will decrease, attention and concentration and memory hopefully all increase. So what are some pearls to remember? Light's a primary tool to rebalance the autonomic nervous system and even the endocrine system. You want to look for that enlarged blind spot and that general constriction of the field. You can think about epsilon omega with D for pain and often is needed in brain injury. And it has a low risk with high rate of success. So I think I stayed within my time. So thank you. That's my email. And I wanted to open it up to questions and even have you maybe tell me, you know, if a few people want to write in the chat or if you're online and can speak, just a couple things that maybe you learned today that were helpful.
All right. Thank you so much, Dr. Cathy, for the informative session. Also, thanks to all the attendees for the
chat at my end is empty right now, so I don't know if you see anything.
Yeah, okay.
Not yet.
Yeah. Okay. So thank you so much for all the attendees for your participation and for your passions. Now we are begin with our discussion session. Let me check the question that maybe you have raised. So let me see the chat. Okay, I can't see any questions. And let me go to the
Yep, something just came up in the chat. So it says, how does syntonic optometry affect brain function, especially in children with sensory processing issues or autism? Well, we know that the entire visual process is taking place in the brain. Light passes through a lot of structures on the way to the occipital lobe, but not only does it start at sort of in a way at that occipital lobe, but it goes much further than that. You have the dorsal stream and the ventral stream. So when you are shining light into the nervous system, between the aspects of the autonomic, parasympathetic and sympathetic, especially because we find that many, many patients who come in, especially today, are very sympathetically driven. And when you can get those fields to open up and you can keep that system more in balance, that person is going to take in more information more quickly, process it more quickly, and make a much faster response. So that is how they kind of override or how we change some of that sensory processing. And for children on the autism spectrum. Now, it doesn't mean the conditions go away completely. We're just trying to provide them with an opportunity for it to be less interfering. And as you know, in any treatment, some patients it goes a long way and some patients it only helps a little, but I haven't had anyone have an adverse reaction to it. So there's only an upside and no downside.
Great. Okay, so we have one more question from the YouTube.
Sure.
Hi, Dr. Cathy. Thank you so much for a wonderful presentation. I wonder which book or course I supposed to follow to enhance the syntonic therapy, and which device you suggest the effective.
Okay, so in terms of learning more, if I heard that correctly, hopefully we'll have a course live over the next few months. We're trying to work on that. We may do part of it online and part of it live, depending what we feel we need to do, given the situation, especially with my inability right now to travel as easily. Um, the other is there are a number of different instruments out there. Uh, and I can't say that I get any reimbursement from any of them, though I have recommended all of them. I think that if you're going to have it in the office, you can start with something that's more simple, and then you can look over time to get something that's more expensive that may hold up a little bit longer, or you may need more than one instrument because if you have a number of patients at the same time, you may find one likes looking in an instrument where they put their head in and it's darkened because of the instrument. Others may want to sit in a room that's more open but dark where you can shine the light on them. I'm also in the process trying to come up with an instrument that will be available more in your area and will be much less expensive than what's out there now.
That's
So
great.
over the next few months, I think we'll be able to have a little more information for you than I have right now.
Okay, that would be great. Okay, so I also got the personal takes. Do you have any such a guideline that any optometrist can follow, like a step by step anything for the syntonics?
For the devices or for how you do the therapy?
How you do the therapy?
Well, basically what I just did, and if you want to distribute it to all the people who have signed up, I can send you the PDF of it and you can distribute it to them. I'm happy to have
Sure.
that done.
Okay.
I will, when we're done with this call, I'll make sure comes out in a nice PDF and I'll send that to you and you can
Thank
distribute it
you.
to them.
I'll
Or
do.
if you want, I can maybe put it out on the WhatsApp group, but I'll let you do it because you know exactly
Yeah.
where everybody checks.
Yes. I'll do that.
Yeah, I'm happy to share that. I don't know that you do that as much there, but here most of the speakers, share their slides and I'm happy to do that.
Okay. Thank you.
Because that will have the basics of it
Yes.
in there. But I do
Mhm.
think you want to think about taking a course, whether one's offered online or when we can do one live in your area. Because, like I said, even when I learned how to do this, I took the course several times over a period of probably 3 or 4 or even 5 years because
Mhm.
you get something different out of it each time. And it really, this was a very quick overview of the normal courses, probably a full day at least, or a little more than that, that's didactic, and then a little bit of hands-on as well.
That will be great. So we are planning for it. Let's see. So let's settle down this problem first, and then maybe you can travel. So when you are coming to the India, so it's a real near. So maybe we can also
Yeah,
plan for
no,
the
I
vacation.
will let everybody know when it's happening. It was supposed to happen in March, but we realized that couldn't
Yeah.
happen, so now we
Mhm.
have to figure out when we can reschedule it.
Sure. All right. I guess this is the question so far. So once again, before ending the today's session, I'd like to express my sincere gratitude towards the presenter, Dr. Cathy, and all the attendees. And also, I'd like to appreciate all the helping hands for the Mero Talks program. So herewith, I am ending the
Yeah.
today's session, requesting all you to provide the review and feedback. So thank you so much. So, Matt, Dr. Kathy, if you have
Thank you.
any
Thank you
notes
for
to, yeah,
having me. Thank you all for giving up your precious time to listen. And I hope many of you will think about adding it to your practices over time because it's a very powerful tool. I was very happy when I added it. I was amazed at how many more things I could treat or how many patients weren't making as much progress in the type of vision therapy that I was doing. And when I added the syntonic phototherapy, they did amazingly well.
that will be great. Okay, thank you so much, doctor. Have a good time.
Good night.
Uh, good night. Thank you.